Can people hear us if we do that? Okay. Apologies, there was a speaker issue. Sorry, everyone. We were saying until I started calling out folks to introduce themselves and they weren't responding, everyone looked like they were nodding along, or so we didn't realize there was an audio issue. Apologies, our fault on that front. Well, we did a little dress rehearsal, but we will properly kick off. I was welcoming everyone, thanking everybody for joining in August, which I know is a tricky time. And then I'd said we have a new advisory council member and a new staff member. So wanted to do introductions, even though we don't typically do that, just so that Katie and Jenny can make sure they can put faces to names. So we will restart that. If there's any other issues with audio, please flag us down, but we'll just start again. So
yeah,
Katie can kick us off.
For those online who didn't hear my speech 2 seconds ago, my name is Katie Seneschal. I am the Senior Data Analyst here at the Office of Affordable Healthcare with May. As a background, I grew up in Saco, Maine, and went to school. I got my undergrad degree at Colby College. From there, I worked in clinical research and then as an evaluation associate for a couple of years, and then just completed my master's in epidemiology down at the Harvard School of Public Health. And in the middle of my 2 years down there, I was the inaugural Fitchie Health Policy Fellow at the Commissioner's Office here at DHHS, which was a great experience for me. I completed a project where I investigated access and service needs among the asylum-seeking population here in the state. And I worked closely with Jordan on that, so happy to be working research side by side again. That is all for me.
Thank you. Perfect. And I was just saying what a joy it's been to have Katie join the team. She's already made a huge impact. And I should put in a plug. We did advertise for another position, so we're still waiting on seeing candidates for that. But lots of exciting progress on the personnel front here in the office. So with that, I'll turn to Jenny, if you wouldn't mind introducing yourself again. Thanks.
I'm Jenny Boyden. I'm an Associate Commissioner at the Department of Administrative and Financial Services, and I'm Commissioner Figueroa's designee to the council. I have about 22 years of experience in state government, mostly in the budget. However, I did work in the Medicaid program for a number of years. And when I was apart from state government, I was the Director of Finance for a federally qualified health center, and I'm now on the board of an FQHC.
Fabulous. Thank you. And Trish.
I'm Trish Riley, retired health policy wonk.
We're saying Trish needs no introduction, given that she knows Jenny. Apologies too if there's folks who already know each other, but again, for Katie's benefit, still nice to introduce. So I will try again at calling out folks who are joining online. And Jordan, can we start off with you?
Yes. Hey, welcome, Katie and Jenny.
We can't hear you, Jordan. Is that only us? I wonder if we're having the same problem. Give us 1 second. The joys of technology.
Try echo cancel. Yes.
There we go. Sorry, we're good now.
Okay, you can hear me? Awesome. All right, well, welcome, Katie and Jenny. I'm Jordan Rhodes. I'm the Director of Research and Policy Analysis within the Commissioner's Office at DHHS.
Perfect. Katie?
Katie Fulham Harris. I am the Chief Government Affairs Officer for Maine Health, and it's very nice to meet you, Katie and Jenny. Jenny, I think we've met before, actually.
Perfect. Thank you, Christy.
Hi there, I'm Christy Daggett. I'm the Chief Financial and Administrative Officer at AMHC, which is a behavioral health nonprofit serving Aroostook, Washington, and Hancock counties. I work from the Presque Isle office.
Thank you. Trevor?
I'm Trevor Putnaki. I'm the CEO of the Healthcare Alliance, which
We are having trouble hearing you, Trevor, and I think we heard the very beginning, and I'm seeing folks online nod, so I think for a change, that one's not on our side. So just a heads up, you were very faint to begin with and then kind of faded out.
Right, I'll try to speak louder. I'm Trevor Putnaki. I'm the president of the Healthcare. I'm in
Trevor from the Health Purchasers Alliance.
The internet is not great.
Okay, and moving along, Mallory. Oh, you're on mute, Mallory.
Yep. Hi, can you hear me okay?
Yep.
Okay, great. Mallory Shaughnessy, recently retired as the Executive Director of the Alliance for Addiction and Mental Health Services. but still participating in this group.
Fabulous. Well, we're glad to continue to have you as part of it, Mallory. And congratulations on the retirement. So to jump right in, I think today is a perfect day to be Katie's first with the team because we have a very data-focused conversation today. She's going to share just a few slides to kind of get us set up, and then she's going to transition to providing kind of a walkthrough of this new data analysis product coming out of the office, the draft, I should say, of this new product. Yeah, no worries. I think very top, the red button. Yeah, that should be great. So perfect. So just to go into a little bit of background on the next slide, just to kind of set up this conversation, I wanted to give just a quick reminder of the elements of the office's statute related to analytics. So the first set of language is that we're directed to analyze cost growth trends in correlation to the quality of healthcare. And then there's an additional directive that is quite broad, as so much of our statute is. So directing us to look at healthcare spending trends by consumer categories, payer type, provider categories, or any other measurement that presents available data in a manner that may assist the Legislative Oversight Committee in understanding healthcare cost drivers, healthcare quality and utilization trends, the impact of emerging technology, and consumer experience with the healthcare system. So, I periodically kind of check back against the statute and think about our structure and what we're trying to achieve, as well as obviously we've talked about analytics a fair amount among this group, both, what are the policy questions that we're trying to answer? What are some learnings and good models from other states that we can follow? And so we've been trying to make forward progress on that in a stepwise kind of manner. I wanted to just give a reminder that even before the office was established, Maine Health Data Organization published a baseline report in 2022 to begin to create some tracking of this that the office could build off of. So a huge thank you to them for being willing to do that and to getting the work started before we even existed formally. But we have been looking at that baseline report as we've been thinking about some other analytics and refining some methodology to make sure that our reporting is sort of consistent, again, across the dashboards that we're producing. So just wanted to kind of give a heads up. We're working with MHDO on some updates to those dashboards, and they're going to be re-released, planning on late September for that. And we'll start referring to them as healthcare expenditure dashboards as opposed to the baseline report to kind of help indicate their role in the wider analytics that we're doing. So we have a slide just to remind folks of what is in those healthcare expenditure dashboards. They are dashboards that cover broadly spending on medical services in the state. So inclusive of spending at hospitals and health systems, independent primary care and specialty practices, as well as other facilities. And the analysis includes a bunch of different filters that allow you to look at different components, including market segment breakouts, looking at demographics like age and gender, geography of spending across the state, and the presence of one or more chronic conditions to sort of identify, are there chronic conditions with higher spending than others, and how does that spending compare to the global kind of spending trend for the full population. So moving on to the next slide, I wanted to start to bring some organization to how I'm thinking about all of the analytics. And before we jump into the product that we're talking about today, kind of talk about what we have produced and what we have access to, what we're planning to produce, and what the analysis we're focused on today, sort of the role that it has in all of that. So the first category on the left-hand side here, Office of Affordable Healthcare Claims Dashboards. This is a universe of different analyses and visualizations of information from claims data that we're able to kind of access or utilize through Maine Health Data Organization, which collects and cleans that data. And I really think of the health expenditures dashboards as a little bit of an umbrella at the top of that category. So it's really the 50,000-foot view of general trend and trajectory of spending. But I think, it's hard to answer policy questions in that, as we found when we talked about it. One of the biggest questions that's a challenge is, okay, if spending is going up or we see a trend, is that being driven by increases in prices, or is that being driven by increasing utilization, for example, because we have a population that's aging here and probably using more healthcare services? So today's focus is on this new set of dashboards that we're calling hospital payment and utilization dashboards that are intended to start to get at that question. We focused on hospitals to begin with for a couple reasons. The first just being hospital spending is definitely the largest segment of spending on medical services. And also from a methodological perspective, it's helpful for us to be able to kind of isolate those facilities. We're able to identify them more easily in claims and kind of cut out any concern about like noise in the data coming from edge cases or different facilities that might not sort of be typical health services. So wanted to start there, but wanted to indicate here that this is just the first of many. We're definitely interested in expanding and replicating this analysis to look at professional services not affiliated with a hospital or affiliated with a hospital, but provided outside of a hospital setting. I'm interested in digging in and being able to look at this facility by facility and at greater levels of detail in terms of services. And then being able to think about when we identify trends and cost drivers doing deep dives. That's really something that we saw in some of the other state reports that we looked at, where, if they saw something that jumped out to them in their higher level dashboards, they could really dig in. So that's sort of the universe of claims dashboards that we envision for the future. Briefly before I hand it over to Katie to share the hospital payment utilization dashboards, I also wanted to just touch on some of the non-claims analysis or some of the non-Office of Affordable Healthcare analysis that we're also looking to. So really wanted to call out the work that Maine Health Data Organization has already done as something that we want to benefit from, engage with, utilize, but not reinvent the wheel or replicate or duplicate. So what came to mind for me there is the drug spending dashboard work that team has already done, and the primary care and behavioral health spending reports that were recently required by the legislature. And there's a year or two on those. So I know there's a robust group of folks engaging in that reporting. So I think that's a great complement and an important aspect or lens to look at spending through, but something where we hope to kind of build and collaborate on that work rather than trying to somehow do that work ourselves in the office. And then finally, really importantly, I know in this group, we've talked a lot about non-claims analyses too, and I think those are also very important. To some extent, we really benefit from the expertise and experience that MHDO brings to claims, but we know there's a lot that's important about the health system and about people's interaction with it that can't be captured or understood by looking at claims. So I have a few broad categories here. Household spending on healthcare being one, really looking at this element of the role of insurance in the perception of an experience of affordability by consumers. I colored this one in the darker blue that I used to kind of try to indicate what is existing because of the work we did with the Urban Institute around projections for 2025. That's not to say that there's not more that we want to do there and thinking about making more replicable analyses, but I do feel like this is an area where we've done some prior work and have a little bit of an understanding of what that looks like in the state of Maine. And then the three other categories that, again, we've discussed previously are thinking about access and equity dashboards. So digging in on survey or polling information that can help us understand how easy people are finding it to actually access services in the state and if there's variation based on demographic considerations that we should know about. Clinical quality metric dashboards. This is something Katie has been looking at since joining the team, and we'll definitely circle back to this group. We want to put together a proposal about how we define and measure quality, again, building on work within the Department of Health and Human Services and by others in the state. But again, important both from the perspective of fulfilling our statute, but recognizing that quality and access are important alongside of cost. And then finally, provider cost analysis. So we've talked a little bit as we consider, trends in pricing, understanding how does that translate into the financial experience of facilities or other providers to understand, what's driving prices from their perspective. So it's a lot to take in, but I found this helpful in, again, just kind of understanding the ecosystem of the different analyses that we're either working to produce or sort of interacting with in the office. So with that, I think I'll hand it off to Katie, who's going to really focus in again today on this hospital services, payments, and utilization section, share some methods, and then provide a walkthrough of the dashboards.
Absolutely. Thank you, Meg. As Meg said today, I'll be reviewing first the methods, and then we'll go through the dashboards and understand what's in there. This is all to say, please stop me at any time for further clarifications. The goal today is really to provide a high-level overview and really level set. I'm sure a lot of what I'll be saying is common knowledge or high-level knowledge for you all. And if there are questions to get deeper into the methods, I'd be happy to answer them here or we're going to be sharing a methodology document and further information that people can use to really understand how these dashboards were put together.
I'm sorry to interrupt you, but I should have said earlier during introductions that we have Karen Lee Harrington from Maine Health Data Organization on. Karen Lee, I won't call on you to introduce yourself now. I think you're probably familiar to most folks on the phone, but just wanted to say, as Katie is walking through, Karen Lee, if there's extra color you want to add, please feel free to jump in. But she is also here to help with any really detailed methodological questions we run into. Sorry to interrupt your flow. Just wanted to make sure
Absolutely.
we gave Karen Lee a little bit of an intro.
Yes, and interruptions are welcome, so please speak up if you have any questions. So just wanted to start by saying that these data today come from the Maine Health Data Organization All Payers Claims Database. This APCD, which is the acronym I'll use to discuss it, covers 100% of Medicaid and Medicare insured individuals and includes about 70% of the commercially insured individuals. And the data today represent payments and utilization, and we'll be defining payments here and in other places as payments made by the payer or the insurance provider, and the member liability, which refers to the amount to be paid by the consumer of those services, which is inclusive of co-pays, co-insurance, and deductibles. And I will mention that these data do not capture uncompensated care, which can be defined as care provided by hospitals for which no payment was received from the patient or insurer. And that's just additional context as we go through these dashboards to understand that we're not capturing that today or looking at that. So the goal of this analysis was really to include all hospital-related claims that can be directly attributable to a Maine hospital and excluding the affiliated practices. So these dashboards include information on 36 Maine hospitals, and the 2 government or state of Maine operated psychiatric hospitals are not included in this analysis. And hospitals are identified in these data using the National Provider Identifier on the claims record. And these claims include only claims that fall into one of the following broad categories, which would be the level 1 service categories based on the billing type code on the claim. And these categories are hospital inpatient, hospital outpatient, and professional, where facility claims related to hospital stays would fall into the hospital inpatient column. And these may include claims in the emergency room that resulted in an admission. Hospital outpatient would be facility claims related to hospital visits that did not result in admissions. And professional claims would be the claims related to clinician services provided at the hospital inpatient, outpatient, or emergency room setting. Next, these data are also categorized further by payer category, so the insurance provider. We have 5 primary mutually exclusive payer categories, and then we've also broken out Medicare into 2 subcategories of original Medicare and Medicare Advantage. To start at the top, our commercial category includes individuals with only commercial insurance during the month that's being analyzed. And these are for individuals under 65 years old. The Medicaid or Maine Care category includes individuals with only Medicaid insurance for that analysis month. And I'll just note, we use the label Medicaid instead of Maine Care in the dashboards under the anticipation that these dashboards may be viewed by people outside of the state of Maine. But for the purposes of this group, when we say Medicaid, we are meaning individuals who have Maine Care insurance. We also have a Medicare group, which combines original and Medicare Advantage. We thought it'd be helpful to see the Medicare group in total, looking at utilization and payment, especially given the recent changes in membership and in enrollment in the state of Maine related to Medicare. We also have a dual eligible Medicare Medicaid group. So these would be individuals with insurance for both of those, Medicare and Medicaid, during the month of analysis. And then finally, our 5th payer category, or 7th, depending on how you're looking at it, is the commercial and Medicare individuals who are individuals with both commercial insurance and either original Medicare or Medicare Advantage for the month of analysis.
Just to add a little extra color, when Katie's referring to sort of changes in Medicare enrollment, specifically what we're getting at there, I think it's a national trend that a lot of people have moved from original Medicare into Medicare Advantage, or there's more of a trend of selecting Medicare Advantage. So this is a change that's going to be made to those overall health expenditure dashboards. Previously, the two were always broken out. So you had to do a little bit of math to understand overall what's the trend in Medicare. So just wanted to give a little extra kind of context to our decision there. And I think it'll be helpful. It creates a little more noise in the dashboards. There's more lines to look at, but it is really helpful if what you're trying to understand is broad categories to be able to look at Medicare as a whole.
Thank you for that context. And then my final slide before we dive into the dashboards. Here I'll define the measures or metrics that we looked at in these dashboards. And I'll go through the definitions now. That is to say, I'm hoping to remember to bring them up as we're viewing the dashboards, or if there's any questions, if people want to see these definitions again, please ask and I'll bring them up again. Here, total payments we're referring to as the combined payments by the insurance provider, and then the member liability, which again is the amount to be paid by the consumer, which is inclusive of co-payments, co-insurance, and deductible amounts. Cost sharing, which is the out-of-pocket amount to be paid by the insured member to the hospital. There's also utilization, where we look at counts of unit of services, and that is based on the service category. For hospital inpatient, that service or unit of service would be days of hospitalization. For hospital outpatient, the unit of service would be the unique person and date in service or procedure specific combination. And then the same thing for professional services. Again, it would be that unique specific person and date of service and procedure or service that they are receiving. We can also look at payments per unit, which is the average payment for services calculated looking at the total payments divided by the number of utilization, whether it's the number of inpatient days for an inpatient service, or for outpatient and professional would be that number of services or specific procedures based on that date and individual. And then finally, we can also look at payments per capita, which is the total payments divided by the sum of member months multiplied by 12. And that's a calculation that we can use to roughly understand the membership or the number of individuals within each of those payers. So looking at total payments divided by the rough number of payers for that category.
Are the payments, total payment figures, is that based on the service date of the claim versus the payment date of the claim?
That is a great question. I do not know that off the top of my head, but can flip that to Karen Lee if you heard the question.
I did. Good afternoon, everybody. And keep on going and I'm going to get an answer because you stumped me. I feel like I think I know, but I want to double check.
Perfect. Thanks, Karen Lee. Katie, I saw that your hand is up, so maybe we can turn to you.
Thank you. How do you account for the difference between payments that we receive, we being hospitals receive for DRGs versus payments that we receive on a fee-for-service basis? And how do you account for days? Is it total number of days before the patient is discharged, or is it days that you're paid under the DRG? I'm trying to figure out how you would account for patients who stay long after their DRG has expired, or the average number of days has expired that would be covered in a DRG.
Yeah, and I think adding to Katie's question, I would be curious about how payments that are made outside of a DRG, like the
Right.
The tax and the tax and match payments, how are those accounted for in this process? Those are overall payments that are made to hospitals, but not claims based.
Yeah, I can answer that question. And then I think maybe, Katie, on your more technical ones, what we can maybe do is take those back. We're actually working, because this has been such a tight process, on the methodology descriptions for these dashboards. And we've already exchanged a lot of those same, what about this and what about that kind of questions. So I'll let Karen Lee chime in after I'm finished if she has an answer, but it might be that that's one we take back. But it's really good feedback for us to know what questions people are asking, which is why we wanted to do this, so that we can anticipate those and share that information along with the release of the dashboards when they're final. I will say just briefly, in terms of non-claims payments, we do acknowledge this is focused only on claims. It's something we're thinking about. I think particularly payments under alternative payment models really important to account for. I do think we're trying specifically to capture, spending on the medical services. And so like, we're not capturing every flow of revenue in, but given that alternative payment models are replacing payment under a fee for service model, that is something we want to think about. I think every state and everyone looking in this area struggles with that. There's not an easy answer about how to do that, but we've been talking with Karen Lee and team about their sort of interest in that area and data that they're collecting to think about how we could expand. But for now, we're just sort of limited more by the data and the degree of confidence in the data that we have available, as opposed to a methodological or sort of decision to exclude those kind of payments.
And would DISH fall into that bucket?
Yeah.
Because I think that is important, the sort of other payments.
Yeah. Yeah, definitely great points. Something to think about for myself when I think about that overall analytics component adding. It's something, like I said, we've had in mind, but maybe for a little bit of the longer term, that piece about how do we account for non-claims based payment for services. Karen Lee, before we move on, I'll just double check if either you or Iwana want to speak to that component of DRGs, and also the sort of count of inpatient days for Katie, or if we should take that one back.
I would agree. There's, in all of this, there's a level of complexity and detail, and I want to make sure we articulate it correctly. So we'll put it in writing. I did pop in the chat the response to the first question, which is service dates.
Okay, great.
Great. So moving on to actually looking at the dashboards themselves. So there.
While Katie is getting that set up, I realized I should have maybe emphasized even more clearly when we were setting up the conversation, just to say again, I shared when I shared the drafts with everyone, but these are very much in draft form. It's a little bit unusual, right, to sort of come to the group and share them when, frankly, there are still things that we were looking at and questioning and going back to check the data on. But that's, I say in part because, again, the methodological questions are helpful for us to take back. And I think today, Katie's walkthrough is going to really focus on just understanding the dashboards, noticing a few trends that we saw, and sort of our hypotheses about what might drive some distinct trend in the data, but also really what we're looking for from the group today and in feedback immediately. We're not at this point sort of saying we're drawing conclusions from these or here are the takeaways. We're really saying, is there anything here that doesn't look right to you or that you question or where clarification is needed, so that we can strengthen the dashboards and make sure that they are in the best shape they can be when we finalize. So just wanted to say that even more explicitly at the top before we jump in. I'll hand it back.
Absolutely. So first, to orient people to the dashboard, there are, when you get to the page, let me just scroll up here so you can see what the top might look like here. There are 5 categories of metrics at the top. And here I've clicked into utilization. I'll go through each one of them so we can look at all of them and all of the possible filter opportunities, but please jump in if anyone sees something they'd like to ask questions about. So starting at the top, once you click into your larger metric tab, you can filter by a couple different sub-metrics within that. So here we can look at utilization count, or utilization per 1,000 insureds, which is capturing per 1,000 people in that payer category. We're also able to filter out of those 3 larger service categories we talked about. We can look at inpatient, outpatient, or professional services to the right here. And then down below that, there are the 2 figures that pop up on most of these pages. If we just focus to the figure on the left and start describing this one here, it is the utilization. Let me see if I can filter that back here. Perfect. On the left are the y-axis here, which again, for inpatient services, that would be the number of the days you're in the hospital. And then on the bottom, we have the years 2017 through 2022. And the graph is showing the total utilization count for each of the payer categories that we described previously. And what you can see here is that this graph to the left again is capturing data that is influenced by the size of the underlying membership group, where we could also look at this graph by utilization per 1,000 insured or 1,000 members. And here we could see a utilization rate that is helping to standardize that underlying membership group. And here what we know is that dual eligible Medicare and Medicaid rose to the top here, which, based on Meg and I's conversations, it makes sense based on the specific needs of this payer population.
Yeah, I'll just sort of add, this is one again where we were reviewing and looking for anomalies in data, and I had a momentary thought of, wow, that line is high. But again, when you think about the population of dual eligibles who are likely to have a disability, significant health needs, that kind of gap makes sense. And then, the other payer categories being a little bit closer made sense to us. So we just kind of wanted to voice that over in case anyone else had a similar reaction to that differential between the top line and others.
Now, looking to the right, I can orient ourselves to this graph to the right. This is looking at year-over-year percent change for the metric which we've clicked on. So this metric that we're looking at is utilization per 1,000 insureds. Our y-axis or our left axis here is looking at percent change across the years identified. And it is a difficult graph, I will say, to visually take in. But we do have the opportunity, if you scroll or if you hover to the bottom, you're able to click, let's say we click on Medicare here, and that payer category will come to the front and the others will shadow in the background. So that's a way to visually, you can see a little bit more what's happening. We also have the opportunity, you can hover over any of these data points and gather information, what those values may be and what that exact percent change is. The same thing over on our left graph here, you're able to hover over there and get those values. The way that I found to click out of this view, which is sometimes tricky, is if you go to the bottom left here and kind of click generally on the screen, everything will pop back up again. And just to show you here how these things may change based on the service category, outpatient services here. And then we can also look at professional services and how these graphs change, looking at these different categories. Next, if I flip over to the payments tab, and please again, stop me if anyone wants to speak up or have any questions. Here we have 3 different metrics we can look at: total payments, cost sharing payments, and payments per capita. So if we start with total payments, for inpatient services, this left graph here again is going to show us total payments in dollar amounts. And again, this left graph, as it is right now, takes into account the size of the membership pool. So our Medicare group is a larger membership pool and has higher payments here. But if we looked at payments per capita or payments per the number of individuals in that membership pool, we see a more standardized values here, where again, we're seeing our dual eligible group, Medicare and Medicaid, or these lines shift based on which metric we're choosing here. And again, we can look at service categories, looking at inpatient, outpatient services, and professional services, and how those lines may change. We can also look at cost sharing payments. So here, cost sharing payments would be the member liability or the amount to be paid by the person actually accessing those services. And we will note that we have noticed this interesting trend in Medicaid payments year over year. And we're working with MHDO right now to kind of try to understand what the data is saying. Here, as Meg said, these data are in draft forms, and we really appreciate all of your eyes on this as well to get a sense of what may be popping out to you as off or not consistent with the trends that you all are used to seeing per se.
And I could just add a little bit more kind of color to that. If you look at the graph on the left side, you'll see that the Medicaid cost sharing amount is very close to zero, very low, which is what we expect based on program parameters. And there were also some policy changes in the Medicaid program during the pandemic around eliminating, in many cases, any out-of-pocket costs for consumers. So, it's possible that's what's happening here is just a couple kind of outlier payments and that's reflecting in the change. So I would sort of say this graph on the right, I think expect likely some changes there. We're digging in a little bit more, but just to get a little bit more of a sense of kind of some of our conversations about what's happening there. Jordan, I saw your hand up.
Yeah, and I think you beat me to it, Meg. I was just going to say it might be helpful to know, just because I know the vertical axis on that left-hand figure makes it a little difficult to see like what the exact values for the Medicaid population is, but maybe like what percent of enrollees like had any cost sharing, and if it is driven by an outlier, it definitely looks like outlier, but it's tough to tell just because it goes from like 0 to 2 million. But yeah, it seems like outlier driven.
2,500, not 2 million, but yes, that's our hypothesis too. So, we can maybe keep an update and share with folks what we learned there. But no, we didn't want this to cause consternation to anyone. We're on the case.
Absolutely. So the next thing that we can jump to is looking at payments per unit, which again, our payments per unit is defined as the average payment for services calculated by the total payments divided by the number of units of that service. So at the top here, we can choose the service category, inpatient, outpatient, or professional services. So here, we are going to pick inpatient services, and on our left graph here, we see average payment per unit for each of the payers. And we can adjust inpatient services, outpatient services, and professional services here as well. Something we've noticed, or I'll let Meg kind of chat about this trend that we noticed on the right here for outpatient services.
Yeah, when we were initially received these and we're looking at the dip in 2021, I was scratching my head a little bit on that, knowing obviously when we see a big utilization drop in 2020, we're all familiar that there was a drop in utilization due to COVID at that time. We talked with some other states, and just in learning from them, we've learned that other states have seen this in their overall claims data resulting from vaccinations. The fact that the volume of claims and low cost claims during the time when there were big pushes for vaccination of nearly the whole population kind of drives down the average in that given year. So we can't say for sure, we haven't done the analysis to say that's definitely what's going on. But again, knowing how much this made both of us say, wait a minute, what's going on there? We wanted to share that with the group, and we'll try and do a little bit more investigating. But yeah, the idea being, in a lot of years, particularly, I think you could say in commercial insurance, you may have people with no claims at all. So given that almost everyone had a couple of claims that were very, very low claims, just is an anomaly in the data.
And then we can also hop over to our overview tab. And this is looking at a higher level. We can also investigate payments, payment per unit, and utilization per 1,000 insured based on the payer category type that we choose up top here. So here, if we stay with commercial under 65 and inpatient services, the left-hand graph will be showing us cumulative percent change from 2017. So, for example, if we look at this data point here, this is suggesting that there's a 3.5% increase in payments per unit from 2017 to 2019. However, our graph on the right will show us year-to-year change. So for the same year, we can see that there was actually almost a 6% drop in payments per unit from 2018 to 2019. So these graphs together will show us trends over time. And we're also able to look again at the different service categories, outpatient, and how these utilization payments and payments per unit may adjust, and then professional services as well. We're able to further look at our public payers, Medicaid, and our Medicare, as well as the other payer categories that we discussed.
I'm wondering if we should just pause. I know there's a couple hands up, so
Oh,
before
yeah,
we
definitely.
maybe get too far away, Katie, I think you raised yours first.
Thank you. Could you go back to the overview for, I think the first one was commercial. I think that will, I think, yeah, that, well, this will illustrate the question I have. And I guess two preliminary questions. The first is, are we going to be able to get the methodology behind all of this at some point?
Yes.
That would be super helpful, including definitions. And I think they're probably readily available, but the methodology tab that's on here is not operational, so that would be helpful. The second is specific to these particular charts, which when you would think that the total payments would reflect payments per unit times utilization. And on most of these charts, the payments per unit, if you go back to the inpatient services, I think that's what we need to be looking at. Yeah. So payments per unit, you can see that utilization is down and the total payments are down, but the payments per unit have increased. And trying to understand sort of what that methodology is, because this sort of defies what one might expect, which would be that the payments per unit would be reflective, the total payments would be reflective of the payments per unit and the utilization, as opposed to being lower than both.
One thing I can say on that front, Katie, just the overall question about the relationship between the three lines, we are representing utilization per 1,000 insureds here. I think there's pros and cons to doing that versus total utilization, but there wouldn't be necessarily always a direct relationship between that and total spending because of fluctuations in the size of the insured pool. So I only wanted to say that to say I don't think it's quite as simple as saying sort of the combination of those two elements result in the other, because we decided to do that more kind of constrained, standardized measure of utilization instead of what is the utilization kind of through the whole population. It is really tricky. I think that intersection between of changes in enrollment between coverage types is one that's hard to capture and represent in any single graph. So feedback well taken, but I just wanted to make sure to point that out as a little bit of a complication in the logic of looking at the dashboards that way.
Okay, that's helpful. Thank you, Meg. And I think maybe for discussion at the end of this today, it would be really helpful, sort of some of those decisions that are being made. We'll have to think of, it would be helpful to hear how you plan, sort of what takeaways you are gleaning from these data and how you plan to roll them out, and sort of what parameters you're going to put around rolling the data out for use, so that we can, be able to speak to it.
Yep, that's a good point. Happy to, we're getting close to the end of the demonstration, but happy to spend a few minutes on that. And we'll just say a little bit of an as usual. I think with all data in this space and all of our analyses, lots of context is always important. So that's very much on our mind. And just to briefly speak to the methodology question, yes, happy to send that around. We thought we might do that in follow-up to this conversation. So we'll just put our heads together and decide. We might be able to answer some of the questions that have been already asked before we circulate, but that'll definitely be available and when finalized, shared. Again, that was a little bit of the choice to kind of have Katie do a walkthrough is again about the fact that these are still kind of in development, and we wanted to be able to have a conversation about that. Perfect. Trevor, you had your hand up as well.
Yeah, I was just wondering, if it makes any sense to split out critical hospitals?
I'm really sorry, Trevor. We can barely hear you.
I'll put it in chat.
Okay, yeah, I was gonna say, I think you said put it in the chat, and I'm happy to kind of read it out loud. Maybe I will let you, I don't know if you had more to walk through.
The last one is just overviewing the trends by service, but if Trevor's question is specific to these graphs.
Well, why don't
Okay.
we keep going and then we can always come back
Perfect.
again.
There it is.
So as we mull over some of the final questions here, the last thing I wanted to show you all is our last tab, which is trends by service, where we can actually look at or assess payments and utilization and the metrics that we discussed today, broken down by services within each of our broader service categories. So at the top here, you can choose any of the metrics we've discussed today. If I click on payments per unit, let's say, and you can look at any of the payers we've discussed. I can stay on commercial under 65. You can then choose one of the 3 broader categories, and then you can click within the broader category and see some of the specific service categories underneath that. So here, I'll just quickly click on a couple to show the differences in payments per unit for these. And you can essentially see how that looks for the different filters that we've chosen here. So the metric payments per unit, the payer commercial under 65 is what we've chosen for this demonstration, inpatient services, and then you can select services within that. And that is the final tab I have. So I'm happy to go back to Trevor's question or.
Yeah, Trevor had asked if it makes sense to split out critical access hospitals, given that they are paid differently, I think particularly by the public payers. I think it's a great point. I will say methodologically that probably would be a challenge to do for a first release of the dashboards, just on the timeline that we're on. But I think that's a great consideration, Trevor, and definitely something worth looking at. I think I had indicated, one of the things that we'd like to do as a next turn on analyses is to be able to look at a facility level too. I think it's interesting to see how things compare when they're not in the aggregate. So either doing that or potentially being able to do some categorization of hospitals, I think would be helpful to be able to compare. Karen Lee? Hopefully I didn't get ahead of my skis on anything there.
Yeah, no, I just wanted to add, and you'll see this when you review the draft methodology, that during the time period that we're reporting on, so 2017 through 2022, Maine Care was not sending us payment amounts for critical access hospitals because they pay the hospitals differently. As is being pointed out, it was not coming through their claim adjudication process, so it was not part of the data that was being sent to MHDO. We've been working with the department. We are now collecting that data as of, I think it was August of 2022. So I just wanted to raise that because you'll read in the methodology section that claims that have 0 payments, and most of those claims are these critical access hospital payments, have been removed from the sample that we are using for the analysis.
Yeah,
The
thank
other
you.
thing-
Oh, sorry, go ahead.
And Meg, I just wanted to say really quickly, and this is in response to the question Katie asked sort of at the beginning of this. So if you want me to hold that, I can.
No, go ahead.
Okay. The only thing I wanted to say is I wonder if it would be helpful at some point to just get a sort of 101 on the claims data that comes in, the data elements themselves, because although the claims data is a rich data source, it does not include every single data element or all of the information that's part of the transaction between, the providers, the patients, the payers. And so although we know what an admission date is and what a discharge date is, because that's part of the data that comes in, we don't necessarily know if there's something around a number of days associated with a DRG. That level of granularity is not part of our data. And we looked at how DRGs, if there are payers that are and providers have negotiated, payment around a DRG. We've looked at how that impacts the data that we're receiving, because remember, claims data, when this was set up many, many, many years ago, was all based on a fee-for-service structure. So over the last couple of years, MHDO, with its board of directors, has been making changes in the file layout to require that the payers start including in their submissions for each claim what type of payment arrangement that claim is paid under. But that didn't start until after this time period that we're reporting on. So I'm only trying to provide, some context in terms of the data is really rich, but it doesn't have everything. And some of this stuff we have to kind of piece together. So I just wanted to put that out there, and we'll try and, as I said, respond to what was asked. But some of it it's not relevant because that's not how the data comes in. So I'll just stop there.
Thank you, Karen Lee. That's very helpful. And I think just a good point to pause on. I will transition and we can talk more big picture in a second. But just very briefly, I think we all acknowledge that there's almost no part of health services research where you can get to a point where you have data that is so completely comprehensive and won't have any nuances that sort of require a caveat. So I think focusing the conversation on, are there elements that we feel like directionally change the outcome or the trajectory or takeaways is the right frame to put on, as opposed to, the really small sort of methodological considerations or nuances. I think important for us to know those and again, share context or caveats where we need to. But I say that mostly to say that, also acknowledge like we have to work with the data that we have for now. Karen Lee and team obviously do an amazing job of thinking about enhancements and changes to make data as comprehensive as possible. But we also can't, sit on our hands and just wait. We need to sort of work with the data we have, I think, to answer questions. And I will say this exercise for me and for us, I think has been really informative in terms of prompting the kind of questions that we want to be asking. We don't always know the answer, but again, when we see those directional changes, asking ourselves why that is, thinking about what are the impacts of these shifts on enrollment mean for coverage and for costs and the global trends has been really helpful. So it's not always about answering questions. To some extent, these kind of data exercises, I think, just help us ask better questions that we may need to use other sources to answer. I will pull up another slide in a second and talk a little bit more about next steps to kind of come back to your question, Katie, about how are we using this and presenting this. But I did want to pause. I see Jordan has a question to make sure if there's others who have maybe questions about the specific dashboards that we capture any of those. So Jordan, feel free to jump in.
Yeah, sorry, I just had one more question. It came from Karen Lee's discussion of the critical access hospital stuff. I completely agree. It probably doesn't make sense to split out critical access with the main care thing. But I was just wondering, would it be possible to do this excluding critical access hospitals? Just because I'm thinking if main care Medicaid payments aren't inclusive of those that went to critical access facilities during the entire sample period, then that will obviously throw off the main care payment interpretation, but it will also, I think, throw off the interpretation of, the growth or change in main care expenditures relative to other payers as well, if that makes sense. So yeah, I guess to get back to the original question, it might be worth doing this just excluding critical access hospitals across all categories, because that will kind of level the playing field in terms of like seeing the changes in cost growth or utilization over time.
Yeah, a couple of thoughts on that, Jordan. I will say in response to that, and thank you again to Karen Lee for flagging, because I should have earlier in the discussion. We had initially had all payer roll-ups in these dashboards that we decided to pull out because we did feel like, that might skew the roll-up. So it is something we'd like to think about adjusting for and being able to do in future. I think I hear you on the implications for Maine Care, but I do think the fact that it would sort of exclude utilization and payment means that, yes, given Maine Care's different payment structures, I guess there could be some directional change, but I also think in general, when you're looking at Maine Care, when compared with, for example, commercial or other coverage types, there's already such a significant sort of disparity in how claims are paid and how prices are set that it raises a question for me of, is it more valuable to exclude all critical access hospitals in order to adjust for that? Or given the differences already, do we just write that off to, we don't expect, Medicaid to necessarily be in line with commercial. So it's good food for thought. I wanted to just respond to a couple of the ways that we were thinking about adjusting for it. And we can definitely take that back, I think, for discussion with Karen Lee and team.
As we look at, or as you mentioned, alternative payment methodologies not being included, do the payer mixes participate in alternative payment methodologies at the same rate? And could that impact some of the year-over-year growth if, as more commercial payers move to alternative payments, if we're seeing more enter in the ACO reimbursements, then flattening of the fee for service maybe and growth in a methodology that we're not capturing?
Yeah, that's a great question. I think given the variation, because I would expect that there would be some variation between, for example, Medicaid and commercial. We will take that one back and give some thought to if there's an adjustment or if that just requires a caveat.
Yeah.
My gut instinct has historically been that it is not so significant, particularly for hospital services, that it would, again, directionally skew results, but we can take a look. I will say one of the charges of the office is to, one of our sort of directives is to monitor the uptake of alternative payment models. I don't think some states do regular surveys and have, I think, a better sense of, for example, in their commercial market, what % of claims are being paid on that basis or what % of payments are flowing through APMs. I don't know that. I would guess that some of the hospital folks would know for their system what that looks like, and others have may have more color, but I don't think we have a comprehensive way of understanding that right now. So I will just say it feeds into another issue that the office is trying to think about, which is how do we wrap our arms around what models are in use and percentages of the population participating in their success.
I would think Medicaid may be a higher percentage than others if that's where you're categorizing the lump sum payments that go out.
Yeah. Definitely. I see Karen Lee's hand is up. So she may have more to add on that as well.
I just wanted to say, Meg, I think that, we just started collecting the information, but, let's explore, because that's exactly the restructuring that we've done in the claims data is now with every encounter, there is a requirement that the methodology for payment be included. So whether it is, a global type of arrangement or a capitated arrangement or whatever it is, there's a whole list of things that the payers can choose from to try and keep the data consistent. So, and that just started. So we do have the ability to look at least starting with the base year and going forward, how things change relative to payment methodologies.
That's great. Yeah, it will be really helpful when we can take a look at that to understand the trend a little bit better. So I will just share my screen quickly, one moment. Just to talk a little bit more about next steps. So to sort of answer Katie's question, we've been pushing and driving towards getting these dashboards into shape in advance of our annual public hearing at the end of September. I have not finally set the date for that. We're just working through some logistical considerations, but we'll have that set soon and we'll start promoting that. And would really like to be able to present these, ideally in advance of that meeting, be able to share them so people can digest a little bit and then do a walkthrough. I will say, obviously, that will include sharing context. That will be part of the intended sort of goal and what I do when I'm walking through them. But I also think that there will be an opportunity for stakeholders to comment on the substance of the dashboards at that point. Again, recognizing that folks may have their own context they want to add or questions that they want to raise about, too quickly, about the substance of the dashboards and the conclusions that we may draw or trends that we may highlight from them, because obviously it's a very rich data source, and I recognize that it's meaningful what we decide to highlight. So that's sort of the plan for rolling these out, and that there will be, again, acknowledging that folks will have different opinions and thoughts about that, an opportunity to kind of share those and have them on the record during the annual hearing process in September, and leading into the final report that we'll submit to the legislature at the end of the year. So just to briefly say, again, on just this quick extra gut check for us from the advisory council, we knew that some people wouldn't have a chance to look before this meeting, would maybe want to digest a little bit after the walkthrough, and hopefully we'll have the methodology out to you soon to take a look at too. So if anyone has additional comments after you kind of chew on this a little bit, welcome sending those to us by the end of the week. Apologize that there's not more time. We just do have tight turnaround times to get this done by the end of the summer. And just want to say another thank you to Karen Lee, the team at HSRI, and the MHDO team for being amazing partners with us on this and doing, the majority of the legwork on creating these. Obviously would not have been possible without them, and they've been really wonderful about prioritizing this and being thought partners. So this is in part to give them a little bit of time to absorb and adjust to comments. And yeah, we had just noted here again the methodology. So we thought this week, but we'll try and push, given that there's the request on those, to get out a version, at least for folks, as soon as possible. Anything more on dashboards? It's a lot to digest, but I will just say I'm also thrilled. This really feels like the first kind of work product. Again, all credit for the production of them itself to MHDO and HSRI, but that we sort of were able to conceive of and talk through and plan for. And again, I do feel excited about its responsiveness, I think, to some of the conversations that we've had in this group in the past as a first step towards being able to answer some of these questions or prompt new ones. So,
and when you present this for the public hearing, will it be with any plain language, what I'm seeing?
yes.
So that we level set with audiences who won't understand this.
Yeah, we will definitely work to make it more accessible. I think we targeted for more of a technical audience here.
Oh, and that's
The public, I don't think is going to be asking about DRGs. So we'll try and hit a good middle ground there where we can, answer questions or address more technical issues, but also speak to it in a way that folks can understand. I will say, we've tried to think through a little bit of finding that balance, even on something like the labeling of payments per unit. For example, I think we felt like that is, the technical correct term, but that's really a way of sort of backing out and talking about what is the price for a service? What are we actually paying? So I think I'm trying to, again, hit the balance and make sure that, folks feel like we are accurately representing the data, but also helping people to understand the logic a little bit. Because I think this whole construct of thinking about payments and utilization is an emerging one. Lots of other states are doing it. And again, within health policy familiar, but for people outside, it might not sort of logically follow.
Yes.
So yes, we will be working on that for sure. Okay, great. Well, then I will move us along. I had one other kind of topic I wanted to talk through today, which is planning for the fall and thinking a little bit about the policy development charge of the office. I just wanted to revisit, I know we've had some conversations and had some speakers from other states come in and sort of begun to just brainstorm a little bit on what is the universe out there. I struggle without structure. I like structure. So I was feeling the need to bring a little bit more structure to that conversation, to think about how we move things forward. I thought I would start by, again, just like we did with the analysis, just returning to the language and statute a little bit again around what the legislature and what the law that established our office was sort of asking us to do. There's a few different lenses for kind of policy development that we've been directed to look through. So one is thinking about improving the cost-efficient provision of high-quality healthcare. I think it's a very similar charge, but it was specifically called out that we also look at proposals to improve the coordination, efficiency, and quality of the healthcare system. So sort of independent of cost considerations, think about those aspects. We're also directed to think about improving consumer experience with the healthcare system. I cut out a reference here. There was some specific language about needs for consumer assistance outside of the programs that are already developed in law. And then finally, some language that was added a little bit later, I think by an amendment to the law to improve healthcare affordability and coverage for individuals and small businesses in the state. So I know we talked through these in either the first or second meeting of this group, but it had been a while since we returned to them. So again, just wanted to say them out loud and share the what I keep checking myself against as we think about fulfilling the mission of the office. And I wanted today, like I said, because I was struggling a bit with just talking about different policy ideas in isolation, to share a little bit of my thinking about how to categorize policies that I think correspond to those topics that we were directed to look at, and then give a few examples of policies within them. And today, definitely, I know I'm springing this on everyone a little bit, not trying to set up a pros and cons or a advantages, disadvantages direction. I'd like to do a little bit more of that conversation potentially at our October meeting, begin thinking about how do these correspond to our interests in the state? How do they correspond to the data analysis work we've been doing and what we hear at the public hearing? But for the time being, I mostly wanted to check from all of you that I am not miscategorizing or missing domains of policies, or maybe missing big kind of policy types or proposals within them that are worth talking through. So I have like a deep dig down slide for each of these, but just briefly, the ways that I had categorized potential policy interventions are subsidizing consumer costs, thinking about constraining the price of healthcare services, to put a finer point on that, aligning incentives for efficiency and quality, I would say, as well. The domain of insurance market oversight for consumer affordability, and provider market oversight being the last. I wanted to put these in the sort of Venn diagram setup because I think there's a lot of overlap. There are certain policies that can combine the two. Several of them have areas of intersection with each other. But again, for purposes of just bringing some kind of construct to the conversation, I thought that it was a helpful kind of paradigm to use. And then I did want to call out prescription drug affordability because I think it's been a salient issue for consumers and for policymakers and for other states. I put it outside of those other policy domains because I do think that the issues around how to legislate or how to regulate prescription drugs are really different than a lot of these others, where there's kind of like a clearer structure for state intervention. So wanted to acknowledge it, but I do consider it just a little bit different in that regard. So to start with thinking about subsidizing consumer costs, several states, and we've heard from a few of them, offer additional subsidies. In general, these are pretty limited to marketplace consumers. They don't tend to be available to small businesses or even in some cases individual consumers outside of the marketplace. And these either lower premiums and or can lower out-of-pocket costs for consumers, so bringing down deductibles or the cost sharing that applies to certain services. Usually, I think in all cases, based on a sliding scale based on income. And states have varied a lot in how high that range goes and exactly how they structure kind of the phase out of subsidies. A few actually have just removed a sliding scale altogether and offer them to the full marketplace. But again, high generalizations in these categories, which will be my caveat on each of them. I had to blend over a lot of intricacies to try to come up with these groupings. But that's the general idea. I think I particularly wanted to call out just because I think it's been relevant in the conversations we've had with other states about these, that they do require state funding, and states have used general revenue. Some have had individual mandates with penalties that they use to raise revenue to support them. And then the health insurance tax that we did hear about, I think for both New Mexico and Colorado as a funding mechanism for the programs that they operate. And briefly, additional funding can be available through 1332 waivers, but requires that you're reducing overall federal spending, which can be quite tricky in any program where you might be increasing the enrollment in the program. So I just called out a couple of the examples to kind of tie back to these state conversations that we've been having, where we've heard from other states, where we got the overview from Maureen to connect this category with what are the things happening on the ground. So the first of those is the turquoise plans that we've heard about from New Mexico, this sort of category of plans on the marketplace that offer reduced premiums and lower out-of-pocket costs to households up to 400% of the federal poverty level. And then another example is California. For 2025, they appropriated higher funding than they had in the past to provide a no deductible silver plan option to marketplace enrollees. They've operated this program for a little while, and it did have a cap in terms of household income on eligibility that they've decided to eliminate. There's some other states too. These are not the only two. There are other states subsidizing consumer costs specifically through the marketplace, but those were a few notable ones that I wanted to call out.
You know, in all of this, the devil is in the detail, but whose costs are we trying to address? You know, because clearly when one subsidizes costs, it's an increase in the healthcare system.
Yeah.
So I think when we go through these options, we need to be clear about the trade-offs.
Yeah, and I will say, I think I tried here to be clear that this is really about subsidizing for consumers and frankly, subsidizing for a subset of consumers, not all. But again, in thinking about what is the action out there, what is happening, this is one category of work.
And then the flip side of if one subsidizes consumer costs, where are the savings on bad debt and charity care, and how are those realized in real dollars?
And I would just say probably anybody that sits in appropriations with me can sense that I'm just almost cringing because I have to leave that hat on too and say, I understand the drive to provide affordable options, but I don't want us to leave out the potential cost of that conversation to either the state or to the healthcare system, for that matter. I know when I had first come back to state government at one time in the old 506 timeframe, we had just made significant changes to the Medicare dual eligible population limits, and with much of the talking points being around the amount of savings that were being accrued. And it took a lot of effort to finally get someone to say, yes, that's savings to the consumer, but there is a cost to state government in doing that. And I just want to be sure that as we move forward and present some of these items, that we are being clear with what the potential cost is, either to us as state government or to healthcare system providers.
Yeah, 100%. I will say, in terms of both general feasibility and considerations for feasibility on the state level, I did not try to speak to that here. I tried to just sort of say, here's the category to think about, because I do think, you know, some of these, again, hopefully in the next meeting where we talk about that, for a variety of reasons, either unique to our state or generalized, you know, where we might say that doesn't feel like a fit for Maine. But again, I'm trying to get us from a place, which I know I've shared with the group I've struggled with, when you're talking about what is the whole universe of interventions essentially in healthcare, to even facilitate that kind of conversation requires a little bit of this grouping together. So, but yeah, point well taken for sure. So the next category is insurance market stabilization and oversight. There's, I think, a couple of not quite competing, but really distinct areas of policy that I was thinking about under this general umbrella. The first being thinking about reducing volatility in insurance markets. Just to kind of skip to the bottom, I would say reinsurance has been by far the most popular way, I think, to do that since the introduction of the Affordable Care Act, and in Maine's case since before then. But there are other ideas, expanding the pool of the market, thinking about the risk mix that you have in a given market to try to just reduce change and uncertainty that can, I won't say artificially, but sort of drive up premiums because of uncertainty among insurers or concern about outlier high cost claims. Then the other, again, very broad category is think about sort of tightening requirements for insurers to make sure that the provision of health insurance is as efficient as possible, that there's as much competition in a market as possible, which may mean more entrants, but it can also promote just competition between existing carriers in a market. One thing I think about there is the goal of clear choice designs and in terms of providing consumers with the ability to comparison shop, which can, pull down costs for consumers. And then I also wanted to note here, especially think about that tricky category that we've been assigned of thinking about improving consumer experience with the health care system, opportunities to reduce friction for consumers and for providers, frankly, by thinking about application of utilization review and prior authorization and what's the right balance between thinking about cost control and genuine concerns about sort of controlling utilization and appropriateness of care with simplification. And so, I think a lot about, we talk about the challenges of affordability here, but a lot of the time my experience of working with consumers is sometimes the biggest pain points for them are things like a claim being denied at first and having to go through long processes for payment. So I wanted to include that here as well, because likely sort of regulation of insurance companies would be the mechanism through which to affect a change like that. I already touched on reinsurance from the state examples, but briefly, Rhode Island's affordability standards I thought were a good example of this too, one of the more comprehensive, where they've really, in their insurance rate review process, which exists here in Maine, they've added in requirements around cost containment, around investment in primary care, and are sort of very active in terms of using insurance as a means to affect some of that change. I know I said I wasn't going to talk about feasibility, but briefly I did at the top here. Just want to acknowledge that I think a limitation there is that states regulate a small component ultimately of the commercially insured market. So it's a little bit of a limitation on this category. Just wanted to double check if somebody had a message in the chat because I can't see it.
No.
Okay. Thanks. So moving along. Provider market oversight and competition, a category that maybe hasn't had as much focus as insurance market oversight in the last several years. But I think recently there's been a little bit of an uptick in states thinking about changes to market oversight programs. In general, I think what's been discussed the most is sort of broadening state authority, thinking about different criteria that extend beyond just localized access and to some extent some localized cost approaches to broadly more what are the impacts on affordability. That can go two ways. I think in some cases it's more oversight on the part of the state. There are other states that are also thinking or talking about, are there barriers to new entry that actually depress competition among providers? So a couple different lenses on that. One of the state examples that connects to what we've sort of learned about and heard a little bit about is Oregon's healthcare market oversight program. I think that's really the one where there's been a concerted effort beyond just sort of including attorney generals in some of these review processes to really empower the state through their health commission to review a wide variety of transactions, and they actually have authority to block transactions or they can impose some restrictions. So if they identify a risk through their review process, they can sort of set requirements for a transaction to try to moderate the impact of that. And then another category that I just thought was interesting and worth calling out, I think it's on the cusp maybe of having more action nationally, is some concern about the role of private equity in healthcare. If folks followed, there was quite a high profile story in Massachusetts around private equity coming in, buying up some sort of at-risk hospitals, but that were serving very high need communities, and some of the actions that they took around sort of selling off the assets of that system really concerning. So I think states are starting to think about how can they proactively sort of guard against that. Massachusetts and California both had legislation this year. I believe just very recently, Massachusetts ended their session without passing that bill, but I think California's session is still ongoing and they're considering this, basically setting different types of restrictions. It's hard to, I think, comprehensively address this, but thinking about additional oversight or finding ways to disincentivize or make it less appealing for private equity to enter their healthcare markets. Next is constraining prices. So I think, states are recognizing that the prices that they are paying for healthcare services, have a role to play in both the household level of healthcare affordability as well as the kind of system-wide concerns that Trish was referencing, and are considering different programs, in some cases to monitor, and others exerting very direct pressure or sometimes more indirect pressure on provider prices. I kind of grouped these, again, lots of nuance underneath them, into a few different categories. Cost growth target programs probably being the most popular. I will say cost growth target programs are not only unique to provider prices. They're often thinking about systemic, sort of all actors in the healthcare system. But I put it here because it sort of made the most sense, I think, in terms of structure under this categorization. And those can vary. Sometimes they really are just about watching and reporting out against a benchmark for the growth in healthcare costs. In other states have authority to put different entities on corrective action plans, report out in some cases to assess penalties if they fail to meet their cost growth targets. So that's one approach that I would say is probably the most popular right now among states in this category of work. There's also reference-based pricing and state employee health programs. Sorry, that's my oversight. So I shared here Oregon is a more recent example of this. Their state employee health plan is prohibited from paying more than 200% of Medicare rates for their in-network hospital services. And then there's a cap of 185% for out-of-network prices. Montana is another example and storied example who used a structure like this in their state employee health plan. And then price caps being used to reduce consumer costs in public option plans. So this is something that we heard about from Kyle in Colorado, and that is also in effect in Washington. Briefly, since we didn't hear as much about Washington's, to kind of contrast with Colorado's plan, their public option plans, Cascade Care plans, have to comply with an aggregate price cap of 160% of Medicare rates for most hospitals. There are exemptions for critical access, sole community hospitals, and others, I believe. But in general, that's sort of one of the means that they implemented to ensure that their public option plans were able to deliver lower costs for consumers in the marketplace.
Have we mixed basic? We're talking prices, but the cost growth target is a cost target.
It is, I think that it's a definitional one.
Right.
They are measuring cost growth, I think, for providers as what is being paid to you. So it's not about them constraining input costs. It's about them constraining sort of the overall payments to them. I know it's a tricky, again, I can only do so much to
No, I know.
try to standardize my my language. I will say I think that part of the reason for cost in that case is because they are applying it to different entities. So they can't say price because they're also requiring insurers not to be spending out. So yeah. I promise there's only a couple more. Bear with me. I know it's a lot. Again, this is a dense meeting that we're having today. This category, aligning incentives to promote efficiency and quality, is I think one that I've been struggling the most to define myself. And I think that some of that is because I know I personally often, when I think policy ideas, focus on legislative, what are laws we need to change. And by and large, I think a lot of the work kind of in this domain happens in other states administratively or just sort of through collaboration and leadership. But really thinking here about delivery system reform efforts, trying to think about how do we change writ large sort of the way that we're paying for services to align with what we want to see in terms of outcomes, quality. I didn't list access here, but I think access is a really important one as well. And just a few examples. This is, again, all of them are big. This is probably the biggest one. But North Carolina just recently established a primary care investment task force. So they have been directed to create an investment target for primary care spending. So, this is really looking at all payers and saying, we want to see a percentage of claims going to primary care to kind of ensure that other spending isn't crowding out primary care spending, which is important, I think, generally for access reasons, but the idea here also being that upstream investment in good health can reduce downstream costs from more intensive interventions. 3 states have global budgets that are multi-payer that we talked about for hospitals. The goals of those, do vary quite a bit. So I tried to be clear here. In some cases, the goal is cost containment. In others, the goal is thinking about provider financial health and how do you reduce or adjust for uncertainty and fluctuations in things like utilization, particularly for rural hospitals. So not all about lowering costs, but more how are you making sure that you're sort of spending wisely to sustain the kind of services that you want to see in your state. And then I think increasingly have been learning over the last 6 months or so about a handful of states that that convene multi-stakeholder delivery system reform work groups so that they can kind of collaborate on goals and think about participation in federal payment models. We chatted very briefly in some prior meetings about the AHEAD model coming out of CMS, which combines primary care investment with a hospital global budget model, voluntary participation, so it doesn't need to be statewide. And I think in assessing that and talking with colleagues here, there's a lot of collaboration between our Medicaid office and the value-based payment team there and providers on Maine care models and, assessing how those are working and innovating and improving those. But sort of thinking about expanding that to include commercial payers, thinking about looking ahead to what's on the kind of frontier, maybe coming from the federal level, is something that is of interest. And I think that there's some examples of other states, doing that pretty well. Finally, my very last one, prescription drug affordability, again, big category, but I sort of felt like there were 3 groupings of the significant policy interventions in this space. So the first being targeting manufacturer prices. I tried to be careful in my language here. It's not always actually obviously regulating those, but thinking about how do you create alternatives to manufacturer set prices or alternatives to the sort of national supply chain, thinking about markups, misaligned incentives along the supply chain, which I think a big category of that would be looking at the role of pharmacy benefit managers, but there can be others too in terms of just how the pricing model for prescription drugs work and role of providers and pharmacies along that as well. And then reducing acute affordability concerns by shifting consumer costs from out-of-pocket payments to premiums. So again, recognizing here that's not necessarily constraining what we're spending on prescription drugs, but asking, are there places where the acute concern that may prevent someone from taking a prescription drug kind of warrants moving away from, let's say, a co-insurance model for a given prescription drug or setting a cap on that. On that last one, I will say, we've done that for insulin in the state of Maine and many other states have as well. But I think there's conversation about other approaches or other drugs that might be worth following a similar model on. In terms of the first 2, just a couple, Colorado, we've called out as well in terms of their very robust affordability work, has a prescription drug affordability board that can deem drugs unaffordable, set up our payment limits. And then Maine has a law in the books that's one of the more comprehensive ones nationally around PBMs, sort of establishes a fiduciary duty for PBMs in relationship to the plans that they are contracted with, and is intended to eliminate spread pricing and some of the other undesirable business practices, I guess is the way that I would put it. I think that is still, sort of being worked on and expanded, though again, a limitation is given that it's at the state level. Some of the ability for that to extend beyond the fully insured market is a little limited. So that was a lot. Yeah.
I wonder on this one if we might want to keep an eye on Medicare. And if their negotiated pricing really works, that seems to me to provide real opportunities for reference pricing to states.
Yeah.
At least on those limited drugs.
Yeah, I'm happy to call that out more specifically. I would put that in the category of targeting manufacturer prices. It's interesting. I'm already losing track a little bit between this group and our PDAB. We had a meeting with them last month where we talked about that. And I was saying that for my purposes, from a policy perspective, I kind of categorize upper payment limits together. And to me, setting an upper payment limit is the same mechanically, whether you are determining what that is using a state process or targeting to it. Yeah. But it's still working to at the state's ability to reach into the market in the state, sort of that the mechanics aren't different by following reference-based pricing. That's my only point.
And related to that, from the state finance side, any of those types of national level, referencing state level changes, we'd want to be cognizant of potential impacts on the drug rebates that we receive now and how, because those are reflected differently in the budget, almost as a savings. They reduce general fund need because we're collecting the rebate.
Right.
So if any of those changes reduce the amount of rebate that we collect, we just need to be mindful of that and the budgetary changes that will have to go along with it.
And specifically, Maine care rebates or
Yeah.
rebates, state employee health plan? Yeah.
Yeah, I wasn't thinking state employee health fund, but that too.
Yeah. Yes, point very well taken.
Yeah.
So that was a lot to go through. I know it's, again, a lot that I threw at you, but it's been a really helpful exercise for me, as I said, to think through this so that we can have more of a conversation at the next meeting where we're not jumping all over the place, but we can maybe take these step by step and dive in a little bit more to some of those pros and cons conversations. I know we have a few minutes now, so I'm happy if there's other thoughts along those lines to take them. But really, my big question for this group, and I'm happy to take feedback via email after folks have a little time to consider and absorb, is am I missing anything here that folks want to make sure is kind of on the agenda for a discussion? So welcome those thoughts again. It's a ton of ground to cover, but I want to make sure that that conversation is kind of as inclusive of the ideas that are of interest to folks as possible.
Can I ask when on that first slide in the Wayback Machine, the cost driver, we'll have some kind of dashboard on cost drivers.
So
When will that be available? Because it seems to me that informs a lot of policy discussion.
it's a good question. I think I was thinking not necessarily of a single dashboard that says these are the cost drivers. I think that looking at payment utilization, being able to expand that to a professional and then look at facility level allows us to begin to look at that in terms of, are there outliers either at a facility level or are there service categories that are big drivers in one or more markets? So to some extent, we have that in this service category breakdown. And then I thought about cost driver deep dives is when we identify that high level trend, then getting really granular with the data. So it would less be a single one and more what I've seen other states do is sort of annually in their annual reports. They do their regular reporting, but then they'll pick a couple topics that are emerging and do a deep dive. So, one I could imagine in the future, it's prescription drugs. So maybe not because we know the challenges of reporting there, but GLP-1s, for example, like that's an area where I think folks will want to be paying attention and looking at what's happening, or there may be others. But yeah, I think it's a iterative and imperfect to some extent process of figuring out how do we make sure the data is informing policy, but also again, we can only go so far with data and we need to overlay our own experiences and knowledge and experiences from other states to figure out what's the path forward. Any other comments, questions? Yep, Katie?
Thanks. First, I wanted to say this is a really nice, this has been a great meeting and you did a really nice job with this presentation. So thank you. I think a question that I've raised before that I just wanted to see if there are other areas related to cost that are on your radar screen, sort of tracking costs. Premiums comes to mind, fairly easy to get that data. But that's another place that would be interesting, I think, to see as we're looking at provider costs, how they're reflected or not reflected in premium costs as well, or costs to employers. So just wondering if that's on the radar screen for you and the team.
It definitely is. I will say accessing that data isn't always as easy. We can look, definitely we have lots of data available on small group and individual market, but what's happening in the commercial side, can be a little bit harder to track. We have been spending quite a bit of time with the reporting through the BOI 940 reporting. I might get that wrong. Their section that gives them authority. So it is something that we're looking at and trying to think about how can we, trend that. But unfortunately, it does create a little bit of a gap when it's a little bit harder to understand what's happening with large employers, which are such a big segment of the market.
Okay, there might be some resources out there that, that are not specific to the MHDO. So I'll see if I can track anything down and bring it back.
Sure, welcome that. And yeah, I was just to add a little more color there. Again, I think the Urban Institute report that we had shared a few meetings ago is helpful. That is projection, but it is projection based on very recent data. That does make it's able to sort of in their modeling make some assumptions about what's happening in large groups. So when they're showing, spending by household income category, that is inclusive of all markets. It's not something that we can replicate year over year and report out on in that model, but it is a place where I think we've tried to demonstrate what's happening with insurance costs, because I do agree, obviously, that's the most salient way that consumers feel costs of the healthcare system. Anyone else? Great. Well, I think I can wrap us up then. I did have one quick housekeeping item in my email sharing the dashboards. I know there were several threads, so it was easy to lose, but right at the end, the Secretary of State's office had reached out because they have some gaps in information about folks. So for anyone who maybe missed that, was just looking for the municipality in which you reside, and then they need a mailing address. The mailing address part will be public. So they did say fine to use a business address, or if folks don't have one of those, we can use the office address in place of that. So just let me know, but it is just one of those things I'm trying to fill out and get back to them so we can check it off the list. So I just wanted to highlight that again in case anyone had missed it. Other than that, we'll be in touch with methodology document, and we can share these slides as well at the time that we send that out. And then just be on the lookout. We'll finalize the date for the public hearing soon and get that out to everybody so they can hold their calendars, very likely here in this room again, like it was last year. And I will say, now that we're a team of 2 and maybe a team of 3 by late September, we are going to do a virtual option for participation. That was just something that structurally I wasn't able to do last time, but it'll be more of a hybrid model where folks can dial in and have a couple minutes to participate if they'd like to do it that way. So more to come on that. All right, thank you everyone again. I hope you're all having a wonderful summer, and we will see you in either September or beginning of October for our next regularly scheduled meeting. Have a good one. Bye-bye.